I'm delighted to introduce our first speaker today, Dr. Joe Ross. He's a professor of medicine in general medicine and professor of public health and health policy and management. After receiving his medical degree at the Albert Einstein College of Medicine, Dr. Ross came to Yale as a fellow in the Robert Wood Johnson Clinical Scholars Program in 2004. He has had a very distinguished career since, with a focus on examining factors that affect the use or delivery of recommended hospital and ambulatory care, as well as clinical outcomes of such care. Today, his topic is leveraging real-world data through pragmatic clinical trials. Dr. Ross, the floor is yours.
Well, thank you, Xiaomei. Thank you for inviting me to speak before the Cancer Center and the part of the Grand Rounds today. I'm delighted to share some of the work that I've been working on over the past several years and to identify potentially opportunities for collaboration with investigators throughout the Cancer Center. I also could not be happier to be sharing the stage with Susan Busch today because, when I was a clinical scholar, kind of lost looking for a mentor way back almost 20 years ago now, Susan was the only person to open her door to me, and she helped me get my career started. So I couldn't be more grateful for everything she's done to help me get started in my career. So I'm just going to get started and talk about this work. Please, jump in with questions through the chat. I'll try to keep an eye on it. Just to note some of the potential competing interests that inform the work that I'm going to be presenting today. I do get research grant funding through Yale from the FDA as part of this Yale Mayo Clinic Center for Excellence in Regulatory Science and Innovation. I'll talk a little bit about that work, as well as from the Medical Devices Innovation Consortium to run something called NEST, along with some funds from Johnson & Johnson for clinical trial data sharing initiatives, federal government awards, as well as the Laura and John Arnold Foundation. So this is just, to get us started. Here, we see some pictures of individuals, searching for evidence to, as they have a clinical question, they're trying to make a decision about what to do for their patients, or to then, sit down with their patient and make a suggestion or recommendation around a drug to use. And, typically, when we think about this sort of the hierarchy of evidence and, what we want to guide our decisions, we look for evidence that, is at this level or higher, randomized controlled trials, to guide our decisions, or perhaps systematic reviews that are aggregating RCT evidence, and ideally when it's been meta-analyzed to put it all together. But there's been a lot of changes in the way we understand evidence, in part because of the advancement in methods to use large data sources, but also because of other challenges that have faced both the FDA and others. But what you'll have noticed over the past decade is, increasingly thinking about new and novel ways to evaluate medical products, and with failings of the past to identify safety issues earlier, you began to see ways to think about what's been called a life cycle approach to evaluation. So it's not just about that first RCT evidence that's going to inform use. And in part that was because pre-market studies that inform FDA approval are often limited in size, limited in scope, limited in the endpoints on which they're focused on. They're not looking at they're not big enough studies to identify important safety concerns. And sometimes they're not even studies that are guaranteed to confirm the efficacy of a product. They're focusing on surrogate markers as endpoints in order to predict benefit through these markers. And those are supposed to be done in tandem with post-market studies, trials that are going to happen after the approval. But the problem has been that those trials frequently are delayed, and they're just not even consistently completed. This, in combination with the fact that we were never ever going to be able to address each remaining uncertainty through clinical trials, has led to opportunities for what you're hearing now, kind of real-world data as the way forward in regulatory science and evaluation. And this quote from a high-level official at the FDA is illustrative. Using RWE to begin to address these questions is preferable to having no evidence whatsoever. And with the advent of industry and FDA talking more about real-world data, you're starting to see more and more companies popping up that are promising real-world analytics to deliver real-world evidence. And I'll just sort of say this is buzzword alert, right? This is a big problem. that where the sort of the promise is getting way ahead of what is actually what we're capable of and what we're capable of sort of understanding reliably. Really, what we're talking about now are the use of cohort studies, case control studies, leveraging observational data resources. And in part, this is not only a recognition of the limitations of pre-market regulatory approval, but also a major advocacy push that's happening towards real-world data that has led to new legislation. The 21st Century Cures Act that passed at the tail end of the Obama administration, had very clear goals that to push towards a real-world data use, including requiring the FDA to establish a program to evaluate real-world evidence, which that was defined in the legislation as data regarding the usage or the potential benefits or risks of a drug or device derived from sources other than randomized controlled trials. Now, this isn't to say that all real-world data are bad. The typical or traditional RWE of today is work that many investigators, including my group at Yale, do, right? So it's advanced observational research, including clinical epidemiology to inform product development, issues around disease prevalence, prognosis, and treatment adherence. This type of evidence is generally used for secondary indication approvals for rare diseases or for diseases that are with well understood pathophysiology and progression. And it's very limited in its use for initial regulatory approval decisions, mostly because those products are not used in such widespread way that you can actually leverage existing data sources to study the effectiveness and safety of the product. And of course, most commonly, these types of studies are used for safety surveillance or registry-based medical device studies. And just to bring your attention to some of the work that we've done as part of our group, and I did want to just sort of flag this in case there's individuals here attending the grand rounds who may be interested in collaborating. I lead a couple of efforts that essentially work closely with FDA to generate evidence to address kind of unmet needs at the agency. This is through our CIRSE. We are one of 4 that are funded by the FDA to do collaborative regulatory science research, but it's also through NEST, which is a network of health systems that are working with real-world data, or essentially we're working with our health system data to try to evaluate medical devices in practice. And these types of studies, tend to look like this project where we try to better understand the safety and efficacy of individuals who are switching from branded levothyroxine to generic, looking at its impact and effect on thyroid stimulation hormone levels and other markers of efficacy. This project where we're aggregating data across the state of Connecticut, including hospital data and mortality data and other vital statistic data, and even EMS data to try to better understand opioid use disorder and overdose, including throughout the state. Work like this where we're trying to understand the comparative effectiveness and safety of oral anticoagulants in patients with atrial fibrillation who have poor kidney function. These types of patients are often excluded from clinical trials, but FDA is often tasked with trying to understand and give direction on their safety and benefits for use of this kind of research, as well as this registry-based study where we looked at different types of cardiac pump devices and looking at their safety, essentially for patients who have an acute heart attack and are in cardiogenic shock. So lots of individuals are doing work like this that are leveraging existing data sources to try to bring greater insights into the safety and benefit of various products. But I think, as the call for real world evidence gets louder, one caution to keep in mind is that observational data sources should not be expected to answer the same clinical questions that are being answered by traditional clinical trials. And we have to think about ways to make sure that the evidence is being used to complement the existing RCT evidence. This is an example of a project that a student working with me did a couple of years ago, trying to understand the feasibility of using real-world data to replicate clinical trial evidence. And what she did is she identified among all the clinical trials that had been published in high-impact medical journals in 2017, she determined what proportion had clinical intervention, the clinical indication of the patients who were studied, enrollment criteria, as well as a primary endpoint that could be successfully and routinely ascertained from either electronic health records, structured electronic health records data, or claims data. And what we found is that only 15% of these trials could feasibly have been replicated using this kind of real-world data resource. When the 21st Century Cures Act passed, the FDA was actually pretty quick to say, listen, real-world data should be defined by the context in which the evidence is gathered in clinical care or home and community settings, as opposed to necessarily in research or academic environments. And the distinction is not based necessarily on the presence or absence of a planned intervention or use of randomization. Essentially, they're saying, continue to seek out opportunities to conduct randomized evaluations using pragmatic trials that better leverage kind of the existing data resource infrastructure to make them perhaps cheaper or easier to conduct. But it's not just about substituting observational data analyses for randomized controlled trials. And I'm always reminded of this quote, if you want more evidence-based practice, you need more practice-based evidence. So in the next 10 minutes, I'm going to talk a little bit about some of the work that we've been doing to try to better leverage kind of pragmatic clinical trials in the hopes of showing you what I think is the future of real-world data investigations. It's not just about leveraging observational data resources. This is a slide from IQVIA, a big data warehouse company that aggregates information across multiple sources. And they talk about kind of all the real-world data that are out there for an individual, from pharmacy data to lab and biomarker data to mortality data, hospital data, claims data, survey data, disease registry data. All these things could ideally be linked together, including even potentially social media data or wearables data, or even something like credit card data. And this kind of is like the optimal environment when you talk to people, like the future of clinical trials. It's going to pull all this information together, putting the patient at the center. And mostly people talk about that as being idealistic and not really achievable. But we've been working with a group called Hugo that actually does just this. It aggregates multiple data platforms into a patient-centered medical record that the patient can then share out with a research team as part of a research project. And so this is the first study we did leveraging this platform. It was done as part of our CIRCE, our FDA-funded center, where we aggregated data for just 60 patients who were getting care at Yale and at the Mayo Clinic. We recruited 15 patients at each site who were undergoing bariatric surgery or AFib ablation procedures. 59 patients actually underwent the procedure and completed our 8-week follow-up. And what's the beauty of this platform for research purposes is you sit down with a patient, you enroll them in the platform, you link their electronic health record data from any health system from which they're gaining care, or as well as their pharmacy data and other information. And that takes time. It took a little over an hour for all of our patients. But once you do that, everything that happens next over the eight-week follow-up for the patients is all passive. Their patient's data aggregates automatically into the system, being shared with the research team for research purposes, and the patient never has to come back. And so, this shows you that we were able to do this, with 60 patients. We've had a nice sort of broad spectrum of age ranges, including a number of patients over the age of 65 who were able to do this successfully. And here are the data we aggregated. And I'll start at the bottom left, the electronic health record data. So everyone was getting care at either Yale or the Mayo Clinic for their specialty care for this procedure, but also, and so everyone, their care is managed through Epic, and they have access to their MyChart, and they connect their MyChart to their Hugo account. But also individuals who had primary care elsewhere were able to link their MyCharts either through Epic or Cerner-based systems from any health system. So if we were taking care of a patient who was getting their AFib ablation here at Yale, but their primary care perhaps was at Hartford Hospital for whatever reason, they could link that system too. Also, we linked their pharmacy data. So that's now the upper right. And so this was individuals who were getting care, their pharmacies, their medications through CVS or Walgreens. They also use a MyChart-based system that allows essentially their health record to get linked right into Hugo. We also then used Hugo to send out surveys, patient-reported outcome measures, both short questions post-procedure, along with longer questions at 1, 4, and 8 weeks. And patients get a link right to their phone. They signify their preference. If they want a text message or an email, they click the link and they fill it all out right on their phone. And it's all kind of easy peasy. They don't have to come back to go through a structured questionnaire with a nurse or any other study coordinator. They can just do it on their own, fill it out. And that allows you to ask more questions. And then we also gave every patient 2 different digital devices. Everyone got a Fitbit in order to track activity. And patients who underwent bariatric surgery got a Withings scale, a digital scale, and patients who underwent the AFib ablation procedure got a 2-finger, a single lead EKG that you measured through KardioMobile. And this is just some quick results to show you kind of what we could do. Again, this was really just figuring out the feasibility of doing work like this. But we were able to link health records for 100% of patients who underwent procedures. 55% of patients also had a primary care that was based at Yale or Mayo. So all of their electronic health records get pulled in for purposes of the study. 10 patients linked an additional 13 portals. And then we had 40% of patients who were getting their prescriptions through CVS or Walgreens. Now Walmart also has a MyChart-like function that allows you to pull in information like medication names, dosages, start and end dates, along with refills. And again, all these data were passively aggregated after initial enrollment, allowing for near real-time streaming data aggregation. And this just kind of shows you kind of how it worked. At the time when we did the study, people had to actually sync their Fitbits. Now that happens automatically, but this shows you, of course, things tail off over time. But even over the 8 weeks, we had well more than half of patients syncing their Fitbits, their KardioMobile devices, and their Withings scale, which allows you to kind of graph the sort of trajectories of recovery. So on the top, you can see kind of average steps per day for patients who underwent bariatric surgery, kind of visually demonstrating how patients recovered over time. The bottom half on the left is the steps per day for patients who underwent AFib ablation. On the right is the cumulative weight change for patients undergoing bariatric surgery. On the lower right is the average heart rate. And again, this was more just to determine, the accuracy, the sort of the integrity of the data that was being aggregated. Here are our response rate to the patient-reported outcome measures, consistently above 80% for all the patients, for all the surveys. And it allows you also to determine how patients are doing. So, we're over time graphing estimates of pain, appetite, and palpitations in the 2 patient groups, but this is really just more for illustrative purposes. And this has led to a lot of future work that I'm really proud of, and I'm really excited. It's all kind of coming soon, but I did want to sort of flag for people in case it prompts potential collaborations. But this is the biggest of the studies that we're working on now, also funded through the CIRSE. We're aggregating essentially a large cohort study of more than 1,500 patients who are receiving a new opioid prescription for acute pain, recruiting from sites across the United States, at Yale, at the University of Alabama, Birmingham, including from their network of dental practices that run up the Appalachian Mountains, from the Mayo Clinic, from Monument Health, which is based in South Dakota, and Cedars-Sinai in Los Angeles. Patients are being recruited in the urgent care settings, emergency departments, dental care, and patients post-cesarean section. We started recruitment in September 2020. We now have more than 1,000 patients recruited, even with all the challenges from COVID. Our primary endpoint is the number of days using opioids, and we're following up patients over 6 months, including additional measures for patient-reported outcome measures from pain and anxiety, other measures of healthcare utilization, activity measured using Fitbits, and opioid disposal. And just to give you a sense of the kind of data that this allows us to aggregate on patients, this is mean daily pain reportings among those reporting they are in pain. And you can just see how pain essentially persists. This is over 180 days. The average pain dots are in blue, worst pain are in red. Here's the median days elapsed to first report of no pain among patients with pain fully resolved. And you can see the difference in pain experienced by patients in different settings, with patients who are recruited either from the inpatient setting or primary care having longer median days until first report of no pain, whereas patients in the dental setting having slightly shorter durations. And then this shows you the mean daily pain ratings among those taking a treatment for pain. And this could be any treatment. It could be Tylenol, it could be an opioid, it could be anything. But you can see here, the blue dots are patients who are not using an opioid for treatment, and the yellow dots are patients who are using an opioid for treatment. And you can see how, on average, the patients who are taking an opioid are having higher rates of pain. All of this is being done in collaboration with the FDA as part of their efforts to better address and understand the risks associated with opioid use. A couple other things just to mention briefly. One is these are projects that are funded by NEST. This is what we call the Sleep Eye study. It's a prospective RCT of 100 patients with depression receiving outpatient treatment for insomnia, comparing usual care of a prescription digital therapeutic device that's essentially cognitive behavioral therapy for insomnia, treating patients over 9 weeks with a primary endpoint of insomnia severity index, and we're following them up over a year. And again, just to emphasize, all of this is done using the Hugo platform. So we enroll patients at baseline. They're randomized to one treatment or another. They undergo, they undergo the treatment associated with that arm, and they get, survey questions out, through their phone or via email, and all of their data, that their healthcare utilization data and other information otherwise passively aggregates. It's a pragmatic RCT that's leveraging real-world data for all of our endpoints. We're doing another study that we call the Heart Watch study, which is essentially an RCT of the Apple Watch, where we're prospectively enrolling 150 patients undergoing cardioversion for AFib. They either get an Apple Watch or they get a Withings watch without an activity. That's just an activity tracker without an EKG and abnormal rhythm notification feature. We're enrolling patients at Yale, Duke, and the Mayo Clinic. We have about 40 patients enrolled thus far. Our primary endpoint is the AFFECT Global Score Questionnaire. It's essentially an AFib quality of life prom. And again, we're following up patients over a year, including additional prompts for anxiety, other measures of healthcare utilization, as well as EKG accuracy. And then last, I just want to note this project we're doing in collaboration with numerous investigators associated with COPPER, the Cancer Outcomes Public Policy and Effectiveness Research Center, led by Carrie Gross, Sarah Mugallen, and Scott Huntington, where we're quantifying physical function in cancer patients undergoing chemotherapy using a clinician-reported, patient-reported, and wearable device data sources. This is being done through our CIRCE, the FDA-funded center. We're doing it directly with collaborators at the Oncology Center of Excellence, a prospective study of 200 cancer patients undergoing frontline cytotoxic therapy, enrolling patients at Yale and Mayo Clinic, 100 solid tumor patients, breast cancer patients, stage 1 through 3, as well as 100 high-grade B-cell lymphoma patients. And our primary endpoint is physical function over 9 months. That's being measured weekly for 2 months and then monthly. Again, all leveraging the Hugo platform for measurements, with patient-reported outcome measures, clinician-reported outcome measures through the ECOG, performance measurement, the 6-minute walk test at baseline and at the end of 2 months, and then again later on, as well as activity measured, as every patient has a daily Fitbit to measure daily steps. And again, part of the purpose of this is to work with the FDA to better understand physical function as a surrogate measure of recovery, compare these data sources, identifying change thresholds, and inform the way the FDA thinks about these measures as part of clinical trials. So I will stop there, and I hope that if anyone has questions, you can follow up. But thanks for the time, Xiaomei. I'll stop sharing.
Thank you very much, Dr. Ross, for this very informative presentation. Renee, I was wondering, do we ask people to raise hands? I'm not sure how this is usually handled. Oh, post your questions in the chat. I do have a question as we're waiting for others to pitch in. I wonder, when you submit work for publication, is it subject to more scrutiny because it's not the traditional trial that people are used to?
Yes, there's a lot of explaining going on when when we're putting these papers together and even just proposing them for funding right now, as people kind of question, like, well, how is this done? I don't get it. How are you pulling in these data sources? But when you talk to people who are clinical trialists and explain the difference in the approach and the efficiency that comes with it, and the kind of trade-offs that are always happen in any clinical trial, but how much more information you can aggregate passively, not requiring patients to come back, minimizing the burden on patients in terms of participation. People see, I get it now. There's great promise to this. And it's not to say that we've worked everything out, but I feel like we're kind of pilot testing new ways to do trials like this, which I hope are going to be useful and informative and set the stage for the future. So it doesn't need to be kind of an all or nothing. We either do a kind of a traditional clinical trial, bringing patient back every couple of weeks for kind of standardized assessment, or we're doing observational data source and analyses. There's a kind of a middle road. I do see there was one question from Dr. Baffa on how to handle contradictory data from the different sources, and that's an interesting challenge, right? In the sense of, how do you, if you see, essentially prescription data in the electronic health record at Yale, but not in the pharmacy data, and how to understand that. And some of it is about understanding the various functions that are used for the data sources, right? A prescription is ordered by a physician at Yale and it's filled at a pharmacy, so that it actually gives you a sense of, adherence, like are patients going and filling their prescriptions. But other times, if there's particularly for the physical function, we're going to have to decide exactly what does it mean if different, patient-reported outcome measures or clinician-reported outcome measures do not align. I see Carrie Gross asked a question around thinking about ways to adapt the EHR and its interface in order to be more proactive in terms of making information like this more readily available. And I couldn't agree more. Some of the challenges, and part of the reason why we're using survey questions out to patients, is because it's not uniformly collected as part of the EHR and then extracted and available to investigators who are leveraging health system data for research or for to inform clinical practice. The more structured data we think about embedding within our EHR, the better the data are going to be, the more it's going to allow us to use kind of actually more typical observational data resources for research. One of the things when I presented that project done by the medical student who identified that only 15% of clinical trials could actually be routinely or feasibly done today using routinely ascertainable information, part of it is because patient-reported outcome measures are not routinely included as part of structured data elements. So there's a real opportunity there. And then the last question I see is about addressing self-selection bias in our data. And I think what Dr. Hooley is referring to is the participation bias, that individuals are going to be more likely to participate in the study, and that raises an issue of bias. I don't think that the selection into our studies is any different than the selection of any individual into a clinical trial. But hopefully, ideally, by lowering the barriers to participation and making it easier on patients to participate by diminishing that burden of kind of having to come in, our trials using this type of approach may be more representative of clinical practice, although that remains to be seen, and it's an important issue for us to address. So I'll stop there so that Susan Busch has plenty of time to go through her presentation.
Thank you, Joe. It is my pleasure to introduce our next speaker, Dr. Susan Busch, who is Professor of Public Health in Health Policy and Professor in the Institution for Social and Policy Studies. She received a master's degree in health policy and a PhD in health economics, both from Harvard University. A number of us have been lobbying for her to join the Cancer Center. I'm very happy when she did recently. Dr. Busch's research examines the effects of policies and regulations on healthcare cost and quality, and she's a renowned and highly respected expert in this field. Today, her topic is insurance coverage mandates and the adoption of digital breast tomosynthesis. Dr. Busch, the floor is yours.
Okay, thank you. Thank you so much, Xiaomei, for inviting me. I just want to make sure, can you see my slideshow? It's working? Xiaomei, you can see my slideshow?
Yes.
Okay, perfect. So first, for those of you who don't know me, I'm a health service researcher and health economist, and I teach at the Yale School of Public Health. I teach advanced health economics here. And most of my work is really around mental health and substance use disorder, with a focus on access to care and how we can optimize benefit design to increase the value of the healthcare system. So I sort of took my knowledge about those issues and now I'm applying it to cancer. So generally, I'm interested, one can think about is as we change payment mechanisms, what are the impacts on access to care, cost of care, and value? And it's always really tough to get at that, idea of value, but I really do strive in my work to do that. So if anybody has any projects related to that, I would love to meet with them. I also have several projects related to tobacco control that people that might be of interest to people. I'm not going to go into detail here about those, but if you're interested, I would love to meet with you and talk about that. So over the past several years, I want to say it's really been a delight to get to know the faculty at the Cancer Center, both at the medical school and also here at the School of Public Health. So in particular, I want to mention Kerry Gross, who invited me to work with his team a couple of years ago and has really taught me a lot about both breast cancer screening and about how to use healthcare claims related to some of the issues that we're going to talk about today. And also, I want to give a big shout out, I hope she's on the call, to Alana Richmond. And this is very specifically related to the work I'm presenting today. Alana is in internal medicine, and she is the first author on this paper. And I can't emphasize enough how much I've learned from having the opportunity to work with her over the past couple of years. So the paper that I'm going to talk about today is the latest in a series of papers related to breast cancer screening, related to issues around patient preferences, diffusion of new technologies, and cost. And this paper is not really focused on value, but also a lot of our papers are focused on that. So this paper has not yet, it's been accepted for publication. It's not out yet, but we're thinking it's going to be out even in just the next couple of days. So. Okay, so these are our collaborators, my collaborators on this paper: Alana, as I mentioned, Jessica Long, Kelly Kayenko, who is at NYU, she's a primary care physician at NYU, and Xiao Zhu, who is also here at Yale, and of course, Kerry. So, over the past decade, cancer screening has undergone a substantial technological shift in the US, in which digital breast tomosynthesis, DBT, has supplanted standard 2D, two-dimensional mammography alone as the standard of care. Advantages of DBT are that DBT may reduce recall, that is, that fewer women are called back for additional testing after screening, and also that it may improve sensitivity, that we may identify more breast cancers using DBT compared to 2D mammography. Yet DBT is still not rated A or B by the United States Preventive Services Task Force. This map is from an earlier paper. So just to get a sense of the variation in DBT adoption, this paper looks at hospital referral regions. So the different geographic regions you see here are hospital referral regions. And we look at 3 years of data from 2015 to 2017. And over this time period, over the US, over the whole US, DBT increased from 13 to 43% of screenings. So this looks very specifically at trajectories And we know by the end of 2017, the lowest use HRRs, hospital referral regions, are about only about 4% of screenings were DBT, while the highest was at 68% of screenings. So there really is significant variation. So related to insurance coverage, really today we're talking about private insurance coverage. And private insurers are not required to cover DBT, and that's because it doesn't have the A or B recommendation by the USPSTF. So absent a federal mandate, many private insurers didn't immediately cover DBT, characterizing it as elective or citing that there might not be long-term data. And states got involved. To date, 17 states, I think it's actually maybe 19 now, 17 states when the paper was written have enacted laws that require private health insurers cover DBT without any cost sharing. So of course, self-insured plans are not covered due to the ERISA exemption, but generally privately insured individuals and women in these states do not have to pay any out-of-pocket payments when they receive DBT screening. So this figure just gives you a sense of the variation in timing of these laws. So we're going to study laws that occurred from 2016 to 2019, and you can see it really is like a staggered implementation. That's really important for identification strategy. Connecticut was the third state to adopt in 2017. So insurance benefit mandates such as these have been widely used in other contexts as a policy tool to protect consumers against high out-of-pocket costs, so it reduces their financial burden, and also to facilitate access to important health services. However, these types of benefit mandates have been criticized by some because they may have some complex effects. Potentially, mandates may contribute to higher insurance premiums, and thereby this may increase uninsurance rates if insurance premiums get prohibitively expensive. There's been some criticism that they may reduce plan benefit design flexibility, and also that increasing the price of a specific mandated service may reduce negotiating power. And this could be particularly problematic for a service or a drug potentially where the supplier has some monopoly power. So our goal in this paper was to evaluate the relationship between DBT coverage laws, the 17 laws that I noted in the last slide, and DBT use, DBT out-of-pocket payments, and also DBT price. So to study this, we use data from Blue Cross Blue Shield Access dataset, which is a de-identified database of health insurance claims. There are claims from all 50 states. So the geographic diversity of this sample, along with the fact that it has a longitudinal structure so you can follow patients over time, makes it really well suited to evaluate policies that vary by state. Within this data set, we identified screening mammographies performed among women ages 40 to 64 between January 2015 and July 1st up through June 30th, 2019. And we have a standard validated algorithm that we've been using to identify screening mammography. I won't get into details on that in this talk. So we did exclude women 65 and over, and the reason we did that is because Medicare is not really represented in these data, or Medicare Advantage as well. And we felt that older women that were then included in the BCBS data might be highly selected. So we use the patient level data to describe the characteristics of the women in mammograms included in the study. But when we do our additional analyses, our event study design, we perform it at the state level. That is, we collapse cells to the state, we aggregate data to the state and 6-month period and use the data in that way. So the exposure that we're interested in this study was a legislative mandate requiring, whether the patient lived in a state that had a legislative mandate requiring coverage of DBT during the study period. All states included as mandate states in this analysis also eliminated cost sharing, with the exception of Connecticut, which eliminated cost sharing 1 year after passage of the general coverage mandate. So in these laws, when we say cost sharing, these are including out-of-pocket payments towards deductibles, coinsurance, or co-payments, similar to what the ACA law is for services that are rated A or B. The control states were states that did not pass a mandate during the study period, and mammograms were assigned to a state based on location of the billing provider. So as I noted, the outcomes we looked at were DBT use, the proportion of screening mammograms performed with DBT among all screening mammograms for a state in a 6-month period. So DBT, as many people probably on the call probably know, is typically read and billed in conjunction with standard 2D imaging. So we consider DBT to have been performed when there was a claim for DBT in conjunction with a claim for screening mammography. We looked at the proportion of women with any out-of-pocket payment. We did also look at the mean out-of-pocket payment. It became not that relevant. So today I'm just going to present results on the proportion that had any out-of-pocket payment. This is women that had out-of-pocket payment. We only looked at those with DBT because women screened with 2D mammography already had no cost sharing, which is mandated by the Affordable Care Act. So we used an event study design, which estimates changes in an outcome among states that passed a law relative to states that did not at each 6-month interval after law implementation. So this specification allows for the effective laws to vary by the time since implementation. So basically what you do in an event study design is you line up the implementation dates and look at whether there are changes in our outcomes in the first 6 months post-implementation than in the next 6 months post-implementation. And this also has the advantage of it allows you to see if there were changes in the 6 months prior to the law. Which you would not necessarily expect, as is typical in any different state level, and models were weighted by the screened population in each state. So this table presents our patient characteristics and outcomes at baseline. We also our no so for our outcomes, it is the outcomes at baseline. So right, okay. At the start of the study period, women in mandate and non-mandate states had similar age. Mean age was 53 in both. Among women in mandate states, 42% lived in the Northeast versus 12% in the non-mandate states. In early 2015, women living in states that eventually passed a DBT coverage mandate, 16% of women who underwent mammography were screened with DBT, versus among women living in states that never passed a mandate, 11%. So the screening rate was a little bit lower in states that never passed a mandate. Note this is before the mandate though. Important to our study, really very few women in 2015 had any out-of-pocket payment for DBT. Only 7% in both mandate and eventual mandate and eventual non-mandate states. You can see that the DBT price was higher than the mean 2D price. For example, in mandate states, the mean DBT price was $311 versus for 2D, $266 pre-mandate. So next we look at DBT use, and here's our first outcome that we look at. So let me orient you because the next couple of slides all have the same sort of framework as this slide. So we lined up implementation dates with the period labeled here, years from law, -0.5, being the period in which the law was implemented. So this shows the percentage point change in DBT use in the period before and the period after the law was implemented relative to states with no law implemented, which is our comparison group. So by construction, the value for the period in which the law was enacted is basically 0% because you're sort of normalizing everything for them to be the same in that moment of enactment. So first thing to look at is if you look at the 3 periods that we can measure here in the period prior to the law, you see that there was no significant effects of eventually passing a law. We find no significant changes in DUs relative to the comparison test. So this is really equivalent to the standard parallel trends test, a parallel pre-trends test that you see in a diff and diff analysis. In the periods after the law, you can see steady increases in mandate states relative to other states. So by 1 year post-law, these differences are statistically significant. 1 year after enactment of a coverage mandate, DBT use increased 7.6 percentage points relative to other states, compared to states without a mandate. I'm sorry, 7.6% greater than states without a mandate. And after 2 years, DBT use had risen 9 percentage points more in mandate states compared to states that did not pass mandates. Next, we look at DBT price. And so it's the same format. I noted before from our patient characteristics table, the average cost of a DBT was $311 among mammograms performed in states that eventually passed a mandate, and $347 in states that did not pass a mandate. And here we find that 2 years post-mandate, and this was a surprise to us, DBT price had declined in mandate states compared to the change in price in non-mandate states, about $38. And I don't have a graph here to show it because we have limited time, but we also did not observe a significant change in the price of 2D mammography. Next, we looked at whether, here it is, at the percent of DBT exams with any out-of-pocket payment, okay, among women screened with DBT. And we found that even at the start of the study, as I said earlier, only a minority of women had any out-of-pocket payments with DBT. We did not observe a statistically significant change in the proportion of women who had any out-of-pocket payments for DBT, even as we go to 2 years post-mandate. We did also look among those that did have an out-of-pocket payment, the mean out-of-pocket payment, and we did not find a statistically significant change there either. So a central policy objective of the coverage mandates, or any coverage mandates, is to ensure access to a particular medical technology or service by protecting patients against financial liability. And indeed, our results suggest that women in states with coverage mandates were more likely to begin to use DBT for breast cancer screening, which probably is one of the intents of the law. And this finding is consistent with other studies across other types of services that found that expanding coverage, and in particular, eliminating cost sharing, can increase the use of specific health services. I'll say it's very difficult in many cases to get patients to change their behavior, but changing even by very small amounts, the amount they have to pay is one way you can get them. Generally, the literature is found to change their behavior. But in our study, this really raises some new questions about the mechanism by which mandates may increase use of an emergent technology, because we didn't find changes in out-of-pocket payments. And even before these mandates, the out-of-pocket payment was low. So it's unlikely that a change in what the patient had to pay is what led to these changes. So one explanation for these findings is that by ensuring payment, coverage mandates may have encouraged radiologists and other healthcare institutions to enter the market and offer DBT. And this may have led to a relative price in at least two ways. One, when more radiologists offer DBT, insurers really may have greater ability to negotiate lower prices. And this could lead to lower prices, or at least slower growth in prices over all providers. Second, it could be the case that early entrants, we would expect the early entrants in this market when DBT first started to be providers that have higher prices. So for example, academic medical centers. If mandates incentivize new entrants who tend to offer services at lower prices compared to established providers, the average price in the market will decrease mechanically. So you have high price providers, lower price providers, the average is going to go down. But in that scenario, no provider has actually changed their price, right? But the price that is paid in the market will decline. So other explanations are possible. For example, it's possible that coverage mandates might be perceived by patients or others as an endorsement of this service. And this could increase interest in this new technology. So we can't say for certain that this is one of the two things that is happening. Unfortunately, we don't have a provider identifier in our data that would allow us to say whether it is different lower price providers entering the market. Okay, I think we need to note some limitations to the paper. So there definitely could be some issues with generalizability since all data was from Blue Cross. It is really, really good data to look at this study because it is from all 50 states in a very large data set. Also, there are important known limitations to using claims data. Claims could be subject to error or misclassification problems or bias. Another issue with this very particular setting is our approach focused, we chose to look at the price of the initial test rather than the screening episode. In some of our papers, we have looked at the screening episode. But that could be very, very different here if DBT does reduce recall, and that could lead to additional cost savings for DBT relative to 2D mammography. Also, this was an observational study. Although we believe we used a study design that intended to limit confounding, unmeasured confounding is always a possibility and could explain some of our findings. Could be, other concurrent legislative policies or other things going on in the market. Finally, although our event study plots didn't show significant differences in DBT use or price prior to the law being enacted, it's important to acknowledge that pre-period trends in DBT use or cost and mandate states may influence our results. So there could be some pre-existing trends. Okay, just to conclude, although DBT mandates were associated with an increase in DBT use, they were not associated with any change in out-of-pocket payments. And this suggests that mandates, and this has implications for other services as well, may influence DBT adoption through mechanisms other than by reducing financial liability for patients.
Thank you, Susan, for a great presentation that clearly demonstrates the close link between policy and clinical practice. I was wondering whether there are studies being planned by you or others to potentially look at the impact of DBT of identifying more patients. I was thinking that eventually, if there's evidence that DBT would identify more patients because increased sensitivity, there might be more incentive for more states to have similar laws mandating it.
When you say identify more patients, are you saying that some people that previously didn't get a mammography would get a mammography because the DBT is available?
Right. I'm just thinking like on what basis would this states that are currently not mandating it? Like why would they be encouraged to do so?
Oh, why would they be mandating? So the first, that is really interesting, especially because we didn't find, like, where's the problem? Out-of-pocket payments were not particularly high sort of before these were mandated. Well, there might be some insurers, there might be some fear from suppliers that insurers may stop covering it or may start start putting in some out-of-pocket payments. I think why would a state not pass a mandate? They may be looking to the evidence and maybe looking to the USPSTF if they're thought of as an independent body. They still have not gone up to the A or B rating, suggesting there may be still some uncertainty, right, in the studies. So that's why you might not mandate. The reason that you, or also because it's not really clear that there's a problem since people are not paying large out-of-pocket payments for this service.
Sure. Yeah, because the law is at the state level, and the U.S. Preventive Task Force hasn't made a A or B recommendation. I think that could be where states are looking for.
Yes. Am I supposed to look for questions?
Right. Please feel free to type your question through chat.
Oh, here's Regina. Thanks so much, Susan. Okay, so Regina Hooley just has a comment that Yale, they first started using DBT in 2011. and they didn't charge patients or insurance for many years, probably not until 2018. So I think Medicare did start charging to $215 till 2015. So I think few private insurers maybe were charging before that. I think I think there wasn't even a code until 2015 to allow people to charge. But that is great that Yale was able to do that.
So what are the follow-up studies that you all carry, your team is planning? I know Ilana has a huge interest in this too.
Yeah, so that's great. And I think we're talking about that right now, because this is one of the, this is a project. I have 2 minutes, so I'll just describe how this project started. And interestingly, Joe Ross was also on this train ride. I had a personal experience with breast ultrasound, which is the technology we were really interested in studying. And Joe Ross and Carrie Gross and I were all on the same Metro North train down to New York for the same meeting. And we were just chatting on the train. And I said to Carrie, what's up with this? What's going on? This is, many years ago. And I said, this is so interesting that they're doing this mandate. Let's write a grant. And we ended up writing an ACS grant that was funded to do this work. And then Alana got on board and we sort of extended it to DBT. So it really did start out as this just sort of kind of very random thing that people just sort of talking. It's funny that Joe was here about this, and ended up being this project. So that project is ended now. So that ACS project is ended. So we're really thinking about what would be the best next steps and what are the most interesting questions. So I think Regina probably has some good ideas. So she's sort of been involved in this. So we haven't sort of gotten to the next project. We're sort of finishing up the old project right now, the older project.
There's a comment from Carrie, if you could address briefly.
I'm not sure that state legislatures would look at that, but I do think like that the advocates, if you say you publish something that suggests that there are really good benefits to passing a law, I think that the advocates may bring that to state legislatures, and that can be very helpful. Especially, I do think like some of the state laws, the earlier studies showing that state laws around mammography, this is pre-ACA and cost sharing, that those actually, led to more mammographies and potentially had some effect on breast cancer identification. Not necessarily, I don't know if they ever got to mortality, but I think those did have an impact, those studies. And there's one more from Alana. Yes, so Alana notes that these implications have other emerging technologies. So to thinking about how that'll those influence adoption and price.
Thank you so much, Susan, for taking the time to share with us your important work. Also, thanks to Joe. Hope you both have a nice day. Bye-bye.